Thank you very much, Donal. Firstly, I want to thank Joe Mulholland for his invitation to address the MacGill Summer School. I think this is the first time a CEO of HICWA has spoken at this prestigious event, and it is a great privilege to do so. I suppose I feel very, very much at home as well as an Ulsterman. The theme of tonight's session is a wholly appropriate theme, and while economics are of course hugely significant, we cannot lose sight of what is of foremost importance, and that is the rights and experiences of people who use services. The promotion of quality and safety in the provision of health and social services is my and HICWA's primary concern. This evening I would like to take the opportunity to engage with you on some challenges facing our health and social care services and how I believe they might be addressed. In spite of some distressing outcomes of many HICWA investigations and inspections in the last few years, tonight I want to take a constructive, forward-looking view. I believe that we are at a critical juncture in respect of our health and social care services, and in my opinion, all stakeholders must play a productive role in improving the quality and safety of these services. This is not to ignore the question of economics, though. I'm conscious that according, and Donal has already mentioned it, to recent CSO figures, expenditure on health and social care in 2014 was 19.1 million. And according to Eurostat, total Irish public expenditure on health in 2013 was the second highest in the EU. And despite this, and considering Ireland's young population and the high prevalence of private health insurance, Ireland ranks in the middle third of OECD countries as regards health outcomes. In fact, on some quality of care indicators, including avoidable hospital admissions, cancer survival rates and volume of antibiotics prescribed per person, Ireland's performance places it in the bottom third. Last year, HICWA published a report entitled Linking the Learning to National Standards. And in this report, and indeed in a number of our investigation reports, we highlight the need for service providers to take measures to avoid unnecessary risk and to create a culture of learning from patient safety incidents. Mistakes happen, but what's inexcusable is a failure to learn from them and to implement agreed change. Tens of millions of euros have been spent trying to solve these issues, yet many of the problems of dysfunctionality in the health service have very, very little to do with money. So where do these dysfunctions exist? Recent controversies, including HICWA's enforcement actions recently against the Irish Society for Autism, have highlighted the need for a more effective accountability when it comes to the provision of effective services and the transparent, fair and effective use of public money. These practices are unacceptable and have starkly highlighted the enduring need for a sharper focus on accountability within those organised charged with procuring and providing services for citizens. Governance and accountability are the cornerstone of any effective health and social care system. This is an already accepted concept, and it's embodied in the national standards for safer, better healthcare, in all other health and social care standards and regulations now endorsed by government. But there is a lack of commitment to address persistent ambiguity in the governance of healthcare nationally and in some instances locally. Accountability must lie with the entity not only that provides but also procures the service. Service providers have a responsibility to deliver a quality, safe service, and as such should be held legally and morally responsible for public funds and how they are spent. And those paying for the service, that is the HSC, on behalf of the state, must also be held legally and morally responsible. One example of constructive effort to get better accountability into the system has been the development of the concept of hospital groups, community health organisations, and the regulation of designated services. In tandem with other health systems internationally, the model pushes accountability of governance and accountability down to a very, very local level. The jury's still out, and progress is frustratingly slow. The governing boards in hospital groups have yet to find their feet. And as the project stalls, should we, as some are suggesting, go back to the drawing board, while applying the same governance principles in a more integrated way? In a recent article, Professor Frank Keane focused on issues within current policy thinking and the impact of the structures of health on health services. He highlighted the fact that there is a potential for some hospital groups to share or be associated with more than one community health organisation, and in one instance up to 5. So he correctly pointed out that this would have a negative impact on care being coordinated, managed, and in some instances comprehensible in terms of patients and their care pathways. And I believe he's right. In addition, and not long ago, the HSE's first Director General, Professor Brendan Drum, proposed a review of the group model in an effort to ensure that Ireland, in line with other countries, ensures that its health and social care structures are integrated across acute and community settings. And having come from the north of Ireland, my experience of working within an integrated setting was a very, very positive one. Whilst far from perfect, the coordination of care between acute and community is organised in a way that promotes consistency and, importantly, accountability. Earlier, I stated that primary accountability rests with the provider of services. However, those who procure services on the state's behalf are also accountable. The idea of a national commissioning body is not a new one in Ireland, but as with all great ideas, it's meaningless without action. The continued absence of a control mechanism in the form of a proper commissioning model is contributing to inadequate planning and poor oversight of service performance. Robust commissioning can contribute to service efficiency and effectiveness, as well as quality and safety. As referenced earlier, the absence of an effective commissioning arrangement led to circumstances such as those we witnessed in the Irish Society for Autism, and indeed in many other services that HICWA has assessed as non-compliant over the past few years. The introduction of a standardised framework to commission services would help as regards an effective service configuration, the implementation of national care programmes, the implementation of strategies such as the new National Maternity Strategy, and effective performance oversight of critical service provision. Such a framework would also drive performance improvement and link payments to the achievement of targets, where the focus is on high quality and safe services. Commissioning is established in many other countries, and these arrangements are not only being applied at national level or regional level, but also the model is frequently replicated at local or community level through primary care commissioning arrangements. And this enables services to be assessed and purchased in line with locally determined need. I think an important fact in our Irish society. If we are to introduce such a system in Ireland, it is important that we get the structures right. And this may mean a radical review of the way in which we currently procure services under Sections 38 and 39 of the 2004 Health Act. The state distributes large sums of money every year to service providers. For example, one charity in the news recently received €125 million a year in state funding. The continued absence of proper commissioning arrangements may in fact promote the perception that there's an element of close your eyes and hope for the best, whereby money is handed over without seeking evidence as to how it's spent, or more importantly, what it delivers for the person in receipt of the service. I believe that the introduction of adequate commissioning systems will not only drive efficiency and value for money in our services, but will be one of the key enablers in the promotion of quality and safety. Any future commissioning model, if it's to be effective, must be accompanied by a reform of approaches to the decisions on the delivery of healthcare services, and these decisions need to be informed by a robust evidence base. Cost effectiveness remains a critical challenge in our healthcare system, particularly when it comes to drugs. The challenge is to spend limited but precious resources wisely. Investing in cancer care, for example, means that there may be less money to invest in neurosurgery. Such investment decisions are crucial if we are to drive safer, better care by maximising outcomes for our population. In recent years, HICWA has been engaged in the delivery of high-quality health technology assessments at a national level to inform major health and policy decisions and health service decisions. HTAs, or health technology assessments, independently assess all the available data and information about a new emerging technology or a health programme, and estimates the clinical benefits and the clinical the clinical benefits it will deliver, and whether it provides good value for money. The need to ensure that scarce healthcare resources deliver maximum benefit for the populations has ensured that health technology assessments have become an embedded part of healthcare systems internationally. Successful implementation of a 10-year vision for health will be driven by long-term planning informed by best available data and evidence, not on crisis management. Health technology assessment is one tool that underpins evidence-based decision-making. In HICWA, we are also concerned that certain areas of high service vulnerability remain unaddressed. One area is the area of home care. As the state's health and social care regulator, we are aware of the specific vulnerabilities of people in receipt of personal care and support services within their own homes. The programme for a partnership government outlines the desire to introduce a uniform service to standardise the quality of home care provision. This is a welcome move. However, it falls short of the need for statutory regulation of the sector, which was pledged previously in a programme for government. Ireland is clearly lagging behind other OECD countries in this regard. The regulation of domiciliary care is now well established in other Western countries in acknowledgement of the vulnerabilities of those in receipt of such services. The Health Research Board has been asked to identify and describe approaches to this issue in other relevant jurisdictions, a move which we very much welcome. However, we would like to see the work progressed and prioritised as soon as possible, and HICWA will certainly contribute further to the development of such arrangements. Another issue which I believe is important and needs to be addressed is that of adult safeguarding. For those of you unfamiliar with the term safeguarding, it's a term used to denote measures which protect the health, human rights and well-being of individuals. These measures enable at-risk adults to live free from abuse, neglect and harm. This is unfortunately another area where Ireland has been slow to respond. It has been a neglected issue over the years, and legislation and guidance is now long overdue. We need to enshrine in law safeguarding of vulnerable adults in acknowledgement of the state's responsibility to protect and safeguard adults who may be at risk or subject of exploitations within a service or as a result of limited cognitive capacity. Such legislation would be closely aligned to the Assisted Decision-Making Capacity Act 2015, which provides a modern statutory framework to assist vulnerable people with limited capacity to make decisions. Effective safeguarding legislation would provide for an explicit power of investigation and prosecution, distinct demarcation of roles for statutory agencies, and clear definitions of offences in respect of those who abuse vulnerable adults. In recent months, in response to circumstances exposed in Oris Attracta, a new National Intersectoral Safeguarding Committee has been established. And one critical objective of the committee is to influence the development of safeguarding legislation and the progression of a range of more effective policies and procedures nationally. HICWA is committed to working with the Department of Health and the Oireachtas to drive forward such legislation. It's a disheartening feature of our health service that well-intentioned reform programmes are put on hold when we hear about the latest trolley or waiting list crisis when it hits the headlines. It's evident that we need to move from a reactive to a proactive approach in health service reform. Political consensus on a long-term strategic policy for health and social care services is required, with the focus being on the safety and quality of care for people who use the services. And in this regard, I welcome the establishment of the Committee on the Future of Healthcare, whose role it is to reach agreement at a political level on the direction of health policy in Ireland, and I look forward to working constructively with the committee in the near future. I also welcome the intention to develop and adopt a 10-year plan for our health service. It's time to put aside the pursuit of narrow sectoral interests and work together on a sustainable, affordable and future-proof model of health and social care delivery. In HICWA, we have a very clear mission to improve health and social care services for the people of Ireland. HICWA cannot achieve this in isolation. We need more than a shared political vision and an agreement on a long-term plan for health and social care services. We also need all stakeholders to co-produce the vision and to guarantee its success. So having highlighted some of these key dysfunctions in our health and social care services, what can we do about them? I believe the key to righting these dysfunctions from HICWA's point of view are fourfold. Firstly, we need providers of services to clearly demonstrate real leadership and accountability in the areas of quality and safety, and that's from the very top down. Policymakers need to ensure that future structural and regulatory reform processes are supported by legislation that enshrines in law the critical concepts of accountability and responsibility. We need a commissioning model that clearly specifies and manages performance and quality and safety. And this model must be based on sound information and sound economic appraisal. And finally, and most importantly, we need to listen to the voices of the public and those who use our health and social care services. In all the noise created by the litany of controversies, the political carousel and the perennial debates on how best to restructure our health service, we cannot lose sight of what is or what should be at the core of our health and social care services, the person using the service. I thank you for your attention, and I look forward to a lively debate.